ഇന്ന് നമ്മള് ട്രെയിൻ നേഴ്സസ് അസോസിയേഷന് വേണ്ടിയിട്ട് മെമ്പേഴ്സിന് വേണ്ടിയിട്ട് TB എലിമിനേഷൻ, അതിന് റോൾ ഓഫ് നേഴ്സസ് ഇൻ TB എലിമിനേഷൻ എന്നൊരു പ്രധാനപ്പെട്ട ഒരു ടോപ്പിക് ഡിസ്കസ് കൂടി മീറ്റിംഗിലേക്ക് എല്ലാവരെയും സ്വാഗതം ചെയ്യാൻ വേണ്ടിയിട്ട് I invite Dr. Sona, President of TINA Kerala Chapter. Over to Dr. Sona.
Thank you, sir. Good afternoon, all. Am I audible?
Yes.
Okay, sir. Okay. So, TB elimination by 2025 is a global strategy which we are striving to achieve. So, I think it's a joint responsibility of all health professionals working in the hospital and also in the community to achieve the same. And nurses can play an important role supporting doctors in this venture by different means like collection of sputum, then counseling patients, then drug counseling, etc., etc. So today's conference on role of nurses on TB elimination is of utmost importance. And without wasting much time, I am going into my duty proper. So I would like to welcome first Dr. M. Narayanan, IIT State President, to the meeting. Welcome, sir. And Dr. Ashraf, Additional Professor of Pediatrics, MCH Kozhikode, is here with us. He is the State Coordinator for Elimination of TB. So welcome, sir, to this meeting. And we have Dr. Sunil Kumar M, State TB Officer. And welcome, sir, officially to this meeting. And next, I would like to welcome Dr. Rakesh P.F., WHO Consultant, Pediatric TB, LTBI Management. Most welcome, sir. And I can see Dr. Balachandra here and other IAP executives on this platform. I welcome all the.
So now unmute സംസാരിച്ചോ.
Yes.
Okay, sir. So I welcome all the executives of TNI and IAP officially in this venture, and all the other organizers of who are participated in this venture, and most importantly the delegates who have come to this platform. I think we have almost 277 participants now on the platform. So I welcome you all to this function. Over to you, sir.
Thank you, Dr. Sona, for the welcome note. Now, may I invite Dr. Sunil Kumar, who is a State TB officer. Dr. Sunil Kumar is in charge of the TB control program or TB elimination program in Kerala State. Over to Dr. Sunil Kumar.
First of all, State TB Cell is very thankful to Indian Academy of Pediatricians for arranging a venue between the Nurses Association and the TB program office bearers. Since the beginning of RNTCP, the staff nurses were already enrolled in the TB control activities, and they were most often acting as the treatment supporter. Erstwhile it was called a DOTS provider. And the role of a staff nurse in the RNTCP was just to observe the TB patients taking the drugs regularly, whether they are developing any adverse side effect, and timely monitoring of the cases in the liver function test and all the other, and also counseling the TB patient. This was the major role played by the nursing staff in the TB control activities. And so after that, the program has changed to a national TB elimination program, and it was become customer friendly, and now 99 DOTS is in place for as a treatment support DOTS provider. And in this scenario, the role of nursing staff in the TB elimination activities has to be defined. As you are aware that we started the TB elimination activities long time back in 2018. And this was launched by the Honorable Minister of Health. And after that, we were facing so many other hindrances due to Nipah, then COVID, and flood, and all these has affected the TB elimination activities. Now, in the midst of COVID, we were able to regain the TB elimination activities, and we launched the Akshaya Kerala project on November, October 2nd, and by the Honorable Minister of Health. And the main vision of the Akshaya Kerala project was to bring the TB services to the doorstep of the patients, so that there is no need for the patient to go to the primary care center or doctor center. And medicine were made available at the doorstep of the TB patients. And moreover, they were given timely counseling. And under the TB elimination activities, we already had 9 lists with vulnerable population in the entire state of Kerala. So that at each Grama Panchayat, there will be a list available of patients that are prone to the tuberculosis, a vulnerable population. And this vulnerable population, we are periodically screening this vulnerable population every quarter, whether they have developed the symptoms and whether, if needed, they will be redirected to the sputum microscopy or CBNAT or RUNAT, whatever is available, whatever the diagnostic modality is available at the site. Now, the state has reached a saturation where the yield from the sputum microscopy is less than 1.5%. Sputum positivity is noted. So, whatever we have gained from sputum microscopy is now saturated, and we had to move towards a molecular diagnostic facility. And by December 1st, at least in one TB unit in each district, the TrueNet service, each district TB unit here, the TrueNet service will be available. So the molecular diagnostics facility will be launched in the entire state of Kerala by December 1st. And for this, we had made available the TrueNet, around 73 TrueNet machines are available throughout the state, and already training has already been given. And apart from this, the traditional super microscopy will be in place for follow-up as well as later the treatment service. And moreover, apart from this, we have the CBNet service also. The state do have around 22 CBNet machines in the public sector, and in the private sector also around 16 numbers is available. And with this facility, we will be able to capture all the presently TBs by molecular diagnostic facility. And apart from this, we do have the X-ray facility also available under the system for the diagnosis of TB. And moreover, from the another point of view, another point of interest that is today's agenda is the latent TB. And we are, after molecular diagnostic facility, we are moving towards the latent TB management. Already IAP has developed the module and it was approved at the Central TB Division, and training has been completed. And we started enrolling children below 5 years under the new latent TB management with the INH and rifampicin. And today's training, we are focusing more on the nurses' role in the TB education activity regarding the pediatric TB diagnosis, because we need a gastric lavage to get the sample from the pediatric stage group, and the training for training for nurses staff how to handle the gastric aspiration will be taken up together. And regarding the newer initiatives and all, Dr. Rakesh, the consultant, will be highlighting. Over to Narayan, sir.
Thank you, sir. Dr. Sona, President of TNI Kerala, Dr. Sunil Kumar, sir, STO, Dr. Balachander, Dr. Rakesh, Dr. Ashraf, Dr. Biju, and my dear delegates registered and logged in large numbers. More than 300 people have already logged in. So, thanks to the office bearers of TNI arranging this session, for responding to our request to have a training program for nurses. Because we all know, as Dr. Sunil Kumar has put it, elimination of TB is not an easy thing. Two main obstacles in this is that diagnosis of tuberculosis is not easy, especially in pediatric age group, where it is difficult to get the sputum sample and make the diagnosis. And another thing is that unlike the other routine common infections that we see, diarrhea or skin infection, the treatment of TB requires prolonged treatment. So there should not be any treatment failure. So apart from doctors, all other people who are involved in the healthcare, and especially nurses and pharmacists, everybody should be supporting, or without their support, this mission will not be a success. Regarding the latent TB management, TB-free air for all children in Kerala just launched It was launched on the 1st of November by the Honorable State Governor, and pediatricians already had 4 sessions of training in TB management. And we have covered almost 90% of doctors. So we thought even in the month of November itself, nurses should get the training. Then only the training program will get completed. So when I requested as STO, he readily agreed. And Dr. Rakesh, who has been coordinating and moderating the training program for pediatricians, readily agreed to take the session. And Dr. Ashraf, who is a convener for the TB program in Kerala for pediatric TB, he also readily agreed to take classes for nurses today. So thanks to both of you for being here with us. And I think if more training sessions are required for nurses, because we are not sure whether this time will be convenient for all sections in nursing. We can arrange more sessions of training also. So without the active support of nurses, TB elimination is not possible. So everybody is aware of that. So we should all join hands together. Medical officers, nurses and field staff, all should be together for TB elimination. With these few words, now I think we can directly go to the training session. I invite Dr. Rakesh, who is a WHO consultant for TB elimination in the state of Kerala. Thank you.
Thank you, sir. Good evening, respected STO, Dr. Sunil Kumar, Dr. Narayanan, IAP State President, Dr. Ashraf sir, Dr. Balajandar, Dr. Sona PS, Ms. Biju SV. So very good evening. Good afternoon, sorry. So I am actually sitting in the COVID cell in Secretariat. So I cannot raise my voice beyond this level. Is that okay? Am I audible at this level?
Audible.
Right. Thank you so much. When talking to nurses, I believe I should talk from the heart. So talking from heart, I feel Malayalam is a better language than English. So is it okay? Is there anybody who is not comfortable with Malayalam in this entire group? Or do you want me to continue in English itself?
I think you can use both languages. That would be better.
Right. No, I am comfortable with English. I am just asking.
Because there's, yeah.
which will be comfortable for the people here. I just wanted to know that, that's all. What I am going to do now is I will just share a brief presentation on the overview of TB elimination activities in Kerala. Followed by that, Dr. Ashraf sir, he will take you through a long session on pediatric TB specifically and the role of nurses. First of all, my sincere appreciations to all nurses in Kerala and outside Kerala for all the health achievements that Kerala state has actually won, ranging from the lowest infant mortality rate to lowest maternal mortality ratio to the lowest case fatality during this COVID pandemic. For all these achievements, I sincerely appreciate all the nurses. So that's why when Dr. Narayanan sir told we're going to talk to 300 nurses this afternoon, I was excited. And I immediately said, okay, I will be there because I wanted to be part of this initiative. So that's from the bottom of the heart. I am going to share my presentation, which will take you through just an overview of TB elimination mission for next few minutes. So it's called Akshaya Keralam, which means Kshay Roga Mukta Kerala. And this actually shows, the blue line shows the effort we are taking in Kerala to detect the TB cases. And this orange line shows the number of TB cases that are actually being notified in Kerala. So what we could see is the effort to find out the TB cases is going up and up every year. It's increasing at 7.5% increase every year. So we are trying our level best to get more and more TB cases. In this background, the cases are actually coming down every year by almost 5% decline we could see every year. So where are these cases going? Are they going to private sector? But private sector drug sales data are also showing an annual decline of 10%. So that clearly tells us that TB cases are coming down in Kerala. So that's clear for us. The TB cases are coming down in Kerala, despite the high case finding efforts. It was in this background, the government of Kerala decided to accelerate the impact of TB elimination. And the entire objective, this is aligned with the sustainable development goals. Sustira Vikasana Lakshangal Kaivarikya, TB-യുമായിട്ട് ബന്ധപ്പെട്ട ലക്ഷ്യങ്ങൾ കൈവരിക്കാനായിട്ട് കേരള സർക്കാർ നടപ്പിലാക്കി വരുന്ന പദ്ധതിയാണ് എൻ്റെ ക്ഷയരോഗ മുക്ത കേരളം. അതിൻ്റെ ഉദ്ദേശങ്ങൾ എന്താണെന്ന് വെച്ച് കഴിഞ്ഞാൽ 2025 TB എലിമിനേഷൻ സാധ്യമാക്കുക. TB കാരണം നമ്മുടെ നാട്ടിൽ ഒരു പ്രിവെൻറ്റബിൾ ഡെത്ത് പോലും ഉണ്ടാകാതിരിക്കുക. TB കാരണം നമ്മുടെ നാട്ടിലെ ഒരു കുടുംബത്തിന് പോലും അധിക സാമ്പത്തിക ബാധ്യത ഉണ്ടാകാതിരിക്കുക. TB കാരണം വിവേചനം അനുഭവപ്പെടാതിരിക്കുക. സീറോ പ്രിവെൻറ്റബിൾ ഡെത്ത്സ് ഡ്യൂ ടു TB, സീറോ കറ്റാസ്ട്രോഫിക് എക്സ്പെൻഡിച്ചർ ഡ്യൂ ടു TB, സീറോ സ്റ്റിഗ്മ ആൻഡ് ഡിസ്ക്രിമിനേഷൻ ഡ്യൂ ടു ട്യൂബർക്ലോസിസ്. സോ ഇതാണ് എൻ്റെ ഉദ്ദേശം. ഐ റിപ്പീറ്റ്, നമ്മൾ മൈക്രോബാക്ടീരിയൻ ട്യൂബർക്ലോസിസിനെ പിടിച്ച് കെട്ടി കടലിൽ മുക്കിത്താഴ്ത്തി എലിമിനേറ്റ് ചെയ്യുക എന്ന് പറയുന്ന പ്രോസസ്സ് അല്ല TB എലിമിനേഷൻ കൊണ്ട് ഉദ്ദേശിക്കുന്നത്. TB കാരണം സമൂഹം അനുഭവിക്കുന്ന ബർഡൻ, ആ ബർഡനിൽ നിന്നുള്ള ഒരു എലിമിനേഷനാണ്. എലിമിനേറ്റിംഗ് ദ ബർഡൻ ഡ്യൂ ടു ട്യൂബർക്ലോസിസ്. TB കാരണം ഒരു കുട്ടികളും അനാഥമാക്കപ്പെടരുത്. TB കാരണം ആരും നമ്മുടെ നാട്ടിൽ മരിക്കാൻ പാടില്ല. TB കാരണം ഒരു കുടുംബത്തിനും അധിക സാമ്പത്തിക ബാധ്യത ഉണ്ടാകാൻ പാടില്ല, തുടങ്ങിയതാണ് എൻ്റെ ലക്ഷ്യങ്ങൾ. ഒരു പക്ഷേ നിങ്ങൾക്കറിയാമെന്ന് ഞാൻ വിശ്വസിക്കുന്നു, ഇന്നും ലോകത്ത് ഏറ്റവും അധികം ആളുകൾ മരിക്കാൻ ഇടയാകുന്ന ഇൻഫെക്ഷ്യസ് ഡിസീസ് ഏതാണെന്ന് ചോദിച്ചാൽ TB തന്നെയാണ്. കോവിഡ് കാലഘട്ടം വന്നെങ്കിൽ കോവിഡ് ഒരല്പം അതിനെ ഓവർടേക്ക് ചെയ്തിട്ടുണ്ട് ഈ ഒരു വർഷത്തിൽ മാത്രം. എന്നിരുന്നാലും കേരളം ഉൾപ്പെടെയുള്ള സംസ്ഥാനങ്ങളിൽ, ഞാൻ ഒന്നുകൂടെ റിപ്പീറ്റ് ചെയ്യാണ്, കേരളം ഉൾപ്പെടെയുള്ള സംസ്ഥാനങ്ങളിൽ ഇന്നും ഏറ്റവും അധികം ആളുകൾ ഒരു സാംക്രമിക രോഗം കാരണം മരിക്കുന്നുണ്ടെങ്കിൽ അതിൻ്റെ കാരണം TB തന്നെയാണ് എന്നുള്ളതാണ് സത്യം. ഈ കോവിഡ് വന്ന കാലഘട്ടത്തിൽ പോലും TB ആൻഡ് കോവിഡ് ആർ കില്ലിംഗ് സെയിം നമ്പർ ഓഫ് പീപ്പിൾ ഇൻ കേരള ഡ്യൂ ടു ലൈക്ക് ആസ് ആൻ ഇൻഫെക്ഷ്യസ് ഡിസീസസ്. സോ അതാണ് പലപ്പോഴും നമുക്ക് മനസ്സിലാകാതെ പോകുന്ന ഒരു സത്യം. ഒരു ഡെങ്കി മരണം ഉണ്ടായാൽ, ഒരു ഡിഫ്തീരിയ മരണം.
Rakesh,
yes,
there's a request in the chat box to use, they will be comfortable if you are using English only.
Right. I'm happy. That's the only thing which I was
Yeah,
looking
because there
for.
may be some people who are not following Malayalam. Okay.
Right. I understood. Okay. Fine. I'm happy. When we look at the TB is still the leading cause of infectious diseases in the world. The same is true for Kerala also. The leading cause of infectious diseases, if you're looking at, it's still TB. Even this COVID times, the death fatality, the number of deaths due to tuberculosis and COVID, if you look at, both are almost same in Kerala till date. So the entire objective I already mentioned is to achieve uh, zero preventable TB deaths, zero catastrophic expenditure for the family, zero stigma and discrimination. And the entire movement of uh, TB free Kerala is visualized as people's movement against TB, the people who are leading this movement. And the theme is My TB Free Panchayat, My TB Free Municipality, My TB Free Corporation. So when all the panchayats becomes TB free or put their maximum effort to become TB free, the entire state will automatically become TB free. So the entire objective is basically the grassroots involvement of the community. TB elimination mission is for the community, by the community, and from the community. So when we look at the components of Kerala TB elimination mission, yes, we need to strengthen the system further to detect all cases of tuberculosis, to treat all cases of tuberculosis, and to prevent further tuberculosis. So we need to strengthen the system. So for strengthening system, we need to have a, this is the most important crucial strategy in a TB elimination mission is strengthening the system further. Then we need to have systems for preventing tuberculosis. We need to detect all tuberculosis and treat all tuberculosis correctly and completely. So this is what is intended. And strengthening system is something which we have been working on. The TB elimination mission is being, I already mentioned, it is being envisaged as people's movement against TB. There are local self-government are being involved in this system in a stewardship role. There are task forces under every panchayat or municipality or corporations for TB elimination. There are district TB elimination boards chaired by district collector in every district. So such kind of system strengthening exercises are happening on one side. Our important agenda is to detect all TB cases. We need to find out each and every TB case that's happening. Detecting TB case is important for two things. Point number one, if you detect TB timely and early, we can save that life. So for that individual, detecting TB early is important. At the same time, when we detect TB early, we could cut down the transmission in the community also. So for two reasons, for cutting down the transmission, the most important reason, and for preventing the individual's deaths, we need to detect all TB cases correctly and completely and timely. For that, we have some systems in place. So one such system is basically this active case finding. So now when we look at the data and when we do the analysis, we are seeing that there is an average of 45 days of delay in diagnosing a case of TB in Kerala uh, once the patient develops the symptoms. Once the patient develops the symptoms, there is an average delay of 45 days in getting a diagnosis of tuberculosis. Within this 45 days, the patient may visit many hospitals, the patient may visit many pharmacies, the patient might have consulted with some healthcare workers also. But still, there is a delay of 45 days. So what has been planned is, what is being executed now is an active TB case finding. So this is something different from the usual passive TB case finding. Usual passive TB case finding is like the patient needs to come to us and say that I have cough. Then we will see, okay, you have cough. Patient again need to say that I have no relief of cough even after taking antibiotics. Okay, then the doctor will think, okay, let's write for a sputum microscopy. But active case finding means we are active, going to the community and trying to find out the TB cases. I will explain that things in detail. Second thing is about the intensified case finding. Intensified case finding is basically the patient come to hospital for some reason, but among the high risk groups, we will screen for tuberculosis. The screening for tuberculosis is different from testing for tuberculosis. Screening for tuberculosis is by asking for symptoms. Do you have cough? Do you have fever? Do you have weight loss? Do you have hemoptysis? Or do you have night sweats? So this is screening for tuberculosis, especially in the setting like Kerala, where most of the TB cases now are coming from specific vulnerable groups. For example, I will narrate few vulnerabilities which is contributing towards TB cases. One, elderly. Now we look at the mean age of TB cases diagnosed in Kerala is 50 years. Most of the cases are above 60 years. TB has become a disease of elderly in Kerala. When we look at other risk factors, the most important one is contacts. The contacts of a TB case is at least at 5 times higher risk of developing tuberculosis as compared to others. I mean the household contacts of tuberculosis. Other risk factors are diabetes. And a diabetes person is 3 times at higher risk of developing tuberculosis as compared to a person without diabetes. Chronic respiratory diseases, tobacco, alcohol, chronic liver diseases, chronic renal diseases. All these are risk factors for tuberculosis breakdown. We all know that we, we, we all might be infected with tuberculosis. I'm sure about that. Being healthcare workers, we are all might be infected with tuberculosis. But one who develops active tuberculosis are the ones with when their immunity drops down. And diabetes, chronic respiratory diseases, tobacco, alcoholism, chronic renal diseases, or immunosuppressive drugs. All these are conditions where we could the immunity drops down and the person may develop tuberculosis. So it's always a good idea to have TB screening at, for example, NCD clinics, like diabetes clinics or tobacco clinics, tobacco cessation clinics, or chronic respiratory disease clinics. Let's have a screening for tuberculosis. The screening means just asking 4 questions. Do you have cough? Do you have fever? Do you have weight loss? Do you have hemoptysis? If anything is yes, we will test for tuberculosis. Now, what test we need to use for diagnosing tuberculosis? We were using sputum microscopy, and we are still using sputum microscopy to most of the cases, but there are high sensitive molecular techniques now available. One such technique is shown in this figure. This is a gene expert machine or a CBNAT machine. CBNAT machine, or otherwise the other technologies are called TrueNAT. It's called NAT. Entirely that technology is called NAT. The full form is nucleic acid amplification test. The nucleic acid amplification test. This is a very highly sensitive and highly specific test for diagnosis of tuberculosis. The sputum microscopy could pick up bacilli only if there are 10,000 bacilli per ml, where at the same time, a NAT machine, a NAT test could pick up if we have 250 bacilli per ml or even less than that. So there is a huge difference of 10,000 bacilli per ml and 250 bacilli per ml. So we could the chance of missing a diagnosis, if it is really TB, is very less when we are using techniques like CBNAT, cartridge-based nucleic acid amplification test, or TrueNAT kind of techniques. Now, Kerala state is moving to offer upfront molecular test for diagnosis of tuberculosis. The sputum microscopy will be out very soon. Like what the state TB officer has told is December 1st. Yes, tomorrow, some of the laboratories in Kerala are actually taking a policy for offering direct molecular test for the diagnosis of tuberculosis. And within 2 months, the entire state will move to diagnose tuberculosis only with high sensitive molecular tests like CBNAT or TrueNAT. And microscopy is no more going to be used for diagnosis of tuberculosis in Kerala. I already mentioned the reason because of the high sensitivity and specificity of NAT techniques. Plus, we need to diagnose cases early in the community to prevent deaths and to prevent transmission. This, I am sure that you all might be knowing this, who is a presumptive pulmonary tuberculosis. Anybody with a history of cough for more than 2 weeks, fever for more than 2 weeks, significant weight loss, hemoptysis, or any abnormality in chest X-ray, they are called as a presumptive pulmonary tuberculosis, and they need to be tested for TB. So when we ask anybody about these symptoms, that is called screening for tuberculosis. And if any of these symptoms are present, we need to test for tuberculosis. And there's a special note here which says contacts of microbiologically confirmed TB patients, people living with HIV/AIDS, malnutrition, cancer patients on immunosuppressants, steroid therapy. I even include diabetes, tobacco, and chronic respiratory diseases. They should be screened for tuberculosis at every possible visit. This will help us to pick up cases early. We are getting now, when Kerala started this intensified case finding, patient might be coming to you in an NCD clinic or a diabetes clinic. But when we ask them, do you have cough, fever, weight loss, or hemoptysis? They may say yes. When we test, we may get positive. And Kerala State has rolled out this strategy of intensified case finding at the NCD clinics in government sector, where every patient coming to the NCD clinics are asked these questions: do you have cough, fever, weight loss, or hemoptysis? And when they say yes, they will be offered a testing for tuberculosis using a highly sensitive molecular test called nucleic acid amplification test. Yeah, this is the picture I would like to show. I already explained this is a gene expert machine or a cartridge-based nucleic acid amplification test. We just need to put sputum sample inside this, wait for 2 hours. This will give you a very highly sensitive test result. A similar technology is called TrueNat. This is the picture of TrueNat. And this technology is again used for diagnosing tuberculosis. Both these technologies are now, either of these technologies are now available in every taluk in Kerala. Every taluk in Kerala has either a CBNAT or a TrueNat now. The additional feature of these techniques are, we could also diagnose rifampicin sensitivity status at the baseline itself. So if for example, if I am being diagnosed with tuberculosis using a gene expert or a TrueNat machine, at the same time, I will also get my results saying you are sensitive to rifampicin or resistant to rifampicin. So this is known as universal drug susceptibility testing for TB. So universal drug susceptibility testing for TB will tell us whether we are sensitive to rifampicin or not for all tuberculosis patients. So there is a activity happening at community, which I already mentioned. I am not going into details of this, where the people who are vulnerability to develop tuberculosis. I repeat, they don't have TB now, but they are vulnerable to develop tuberculosis. For example, contacts or people with tobacco, alcoholism, smoker, diabetes, chronic respiratory diseases. There is a separate list available in the panchayats now. Some of the urban areas and corporation areas have its weakness, but in panchayat rural areas, those lists are available, and community workers like ASHA workers are going to them and asking whether they have cough, fever, weight loss, or night sweats. If they say yes, they will be tested for tuberculosis. This is a strategy to pick up cases early so that we could prevent mortality. At the same time, we could prevent transmission in the community also. This is the intensified case finding at non-communicable disease clinics, where a 4S seal is used. What is 4S means? 4 symptom complex. What is 4 symptom complex? 4 symptom complex says fever, cough for more than 2 weeks, night sweats, and weight loss. So any of these symptoms are present, these 4 symptoms, any of these 4 symptoms are present, they need to be tested or evaluated for tuberculosis. So this is happening in every NCD clinics. So my sincere request to all the nurses present here, our first responsibility or the role will be to diagnose all TB cases at the earliest. For that, we need to specifically ask for TB symptoms among the vulnerable groups. So if when we are encountering with any individual who is vulnerable to develop a TB in Kerala, I repeat, elderly, diabetes, chronic respiratory disease, people on immunosuppressive therapy, people with chronic respiratory diseases, tobacco, alcoholism, or anybody with contacts, just ask for, do you have cough, fever, weight loss, or hemoptysis? If any of these symptoms are present, let him get or her get tested for tuberculosis. So this is my first request today. There are active case finding happenings at elderly homes, congregate settings, prisons, kind of stuff. This will happen outside the hospital. So when we are inside the hospital, just focus on NCD clinics, focus on chronic respiratory disease patients, focus on malnourished patients, focus on people living with HIV, focus on people who are on steroids, immunosuppressive therapy, organ transplants, cancer patients. Ask them if they are saying symptoms, any of these 4 symptoms, including cough, fever, weight loss, or hemoptysis, or night sweats. refer them for a TB testing. TB is a disease of elderly in Kerala among people with vulnerabilities or the risk factors I mentioned. So with this, we could diagnose TB cases early. I'm sure that you will be knowing about the treatment regimen now are being used for a drug sensitivity TB. I already mentioned that we are measuring resistance to or sensitivity to rifampicin at the baseline itself. That's called universal drug susceptibility testing now. Every TB patient in Kerala will know their rifampicin sensitive status at the baseline itself using this test. So for a drug sensitive TB patients, we have a regimen which is 2 months of HRZD plus 4 months of HRE. HRZD isoniazid, rifampicin, pyrazinamide, ethambutol, 2 months plus 4 months of HRE, isoniazid, rifampicin, and ethambutol. So this is the regimen now being used. Previously, RNTCP program was using alternate day regimen, but now we are following daily regimen. So daily doses are being given to patients for 6 months. 2 months of intensive phase, 4 months of continuation phase, 6 months daily doses. And this is the now what is available with the program is a fixed dose combinations. Previously, we need to take isoniazid separately, rifampicin separately, pyrazinamide separately, ethambutol separately. But now fixed dose combinations are available. That means the same tablet contains all 4 drugs. So these tablets are available with the program. It is being made available to the private sector also through the STEPS initiative. This is the 3FDC. 3FDC means isoniazid, rifampicin, ethambutol combinations. 3 drugs, fixed dose combinations. There are other strategies to reduce the mortality. The important strategy is basically something called a fortnightly clinical review. Because when we looked at why TB patients are dying in Kerala, most of the reasons were not TB. Most of them died due to complications of diabetes, complications of hypertension, stroke, carcinoma, myocardial infarction, and many other non-communicable disease-related events. I repeat, 70% of patients who are on TB treatment died in Kerala due to complications of non-communicable diseases like diabetes, hypertension, kind of stuff. So what we need to, if we need to reduce deaths among TB patients, if we want to make sure that no TB patients are dying in Kerala, one I already mentioned, we need to diagnose them early. For that, we know what to do now. Second important thing is a clinical review. We need to review not only TB condition, we need to check their blood pressure, we need to check their blood sugar status, we need to look for other comorbidities also among the TB patients. So what government is following is a fortnightly clinical review, which says every TB patient need to be seen by a medical officer or a staff nurse at least once in 2 weeks. It could be even phone also, doesn't matter, but somebody need to assess their clinical comorbidity and manage that. Somebody also need to look for adverse events because some of these drugs are having adverse events ranging from hepatotoxicity to peripheral neuropathy to rashes, gastritis, vomiting, all these kind of stuffs are there. Okay. Then another important aspect is treatment adherence support. As State TB officer rightly mentioned, it is and it will be the nurses who are actually the patient's most trust. The patients trust most about the words from the mouth of a nurses. I'm sure about that. Even I do that. So that means when the nurses talk to patients regarding all these kind of things, we also need to ensure their treatment adherence support also. We also need to counsel them regarding the importance of taking medications, what all things they need to do, all these kind of things. I'm not going into details of that. I'm sure that you all know about that. There are other schemes, welfare schemes by the government, where now Revenue Department of Kerala is providing 1,400 rupees. It's not 1,000 now, 1,400 rupees per month for TB patients with annual income of less than 1 lakh per month during the entire treatment duration. For example, patient's treatment is for 6 months. The government will provide them rupees 1,400 into 6 months. Every month they will give 1,400 rupees, the TB patients. There are other provisions called direct benefit transfer, where every patient, irrespective of their income status, will receive rupees 500 per month to their bank account directly from the central government. So this is called Nikshay Poshan Yojana. So a patient who is really BPL will get this 500 rupees plus 1,400. So approximately 1,900 rupees per month government is providing directly to the bank account of a poor patient. This rupees 500 is for every patient. So every TB patient diagnosed, irrespective of the income status, they will get this rupees 500 rupees. And I'm stopping very soon, but I am just talking about the public health actions also. Uh, TB is not only a medical disease. We all know that it's a social disease also. Plus, there are lots of public health actions involved while treating a case of tuberculosis. We need to counsel them. Medicines will cure their TB, but many of other things we need to take care of. For example, we need to counsel the TB patient and their family. We need to ensure their treatment adherence, support, and follow up. The contact tracing is an important thing because I already mentioned contacts are the people who are likely to develop tuberculosis. So if we have a TB patient, we may need to ask him to bring his contacts also, for example, his wife, children also, and look for TB. And this is not a one-time activity. We may need to repeat it frequently, for example, every 3 months, because we all know that once we are infected now, we may get TB disease when the immunity drops down. So this can happen anytime in the lifetime, but most importantly in the initial 2 years. So at least for the 2 years, all the contacts of a microbiologically confirmed TB case, we need to follow them up and ensure that, ask them for symptoms. That's so simple. Do you have cough, fever, weight loss, or hemoptysis or night sweats? If anything is there, let us test for TB. And we need to give prophylaxis to the children. I'm sorry, this is an old slide. Dr. Ashraf sir will tell you about how the prophylaxis is going to be. Offer HIV counseling and testing for all TB patients, because HIV patients, most of the HIV deaths in our country are due to tuberculosis. Most of the HIV patients are dying due to tuberculosis. So HIV is a condition and TB is an opportunistic infection. So we need to test for HIV. At the same time, in Kerala setting, we need to test for diabetes also. All TB patients need to be tested for their diabetes status. All diabetes patients need to be screened for TB. I repeat, when I say screen for TB, I mean, ask them about symptoms. Do you have cough, fever, weight loss, or night sweats? So all TB patients need to be screened for diabetes, and all diabetes patients need to be screened for TB. Why I am saying is, out of all the TB patients in Kerala, 45% are people with diabetes. I repeat, out of all the TB patients in Kerala, 45% of them are having diabetes also with them. So diabetes screening and managing is important as far as TB is concerned. Also, we need to look for the drug susceptibility testing. I already mentioned all TB patients need to be offered a molecular test to know their rifampicin status at the baseline itself. If they are resistant to rifampicin, they cannot be treated with our usual drugs like isoniazid, rifampicin, pyrazinamide, ethambutol. There is a different regimen which we need to provide for the TB patients. Also, we need to link them with the social welfare and support schemes. I already mentioned the TB pension by the Revenue Department of Kerala, the direct benefit transfer by the central government. There are other welfare schemes like nutritional support schemes by the local self-governments. So all these schemes are available. We just need to link them. And most importantly, we need to counsel them on the airborne infection control measures at the household. So airborne infection control households at household is an important step that we need to counsel them. In this context of COVID, now everybody will realize that how the airborne infection control measures need to be. We just need to wear a mask, dispose the sputum properly for all the TB patients. We need to counsel them. We need to ask them to remain in a well-ventilated room. We also need to ask them to stay away from children or elderly till their smear or anything becomes, till their treatment period or their smear becomes negative. For treatment adherence mechanisms, there are different techniques available. One such technique is called 99 dots. I will show what it is. Nutritional supplementation is being provided to TB patients by some of the panchayats. There are treatment support groups available at the panchayat level also. And now listen carefully. This is what is known as 99 dots. This is available for adult patients now. The right side we are seeing are the tablets. We are putting the tablets inside a strip. Okay, this is an envelope. On the back side of the envelope, there are phone numbers. You could see when we open the tablet, when the patient opens the tablets, there is a phone number. There's a toll-free number. The patient just need to dial that number. Okay, I repeat, when the patient opens the pill, there is a phone number. It's a toll-free number. It's free of cost. We can dial that number. The patient need to dial this number from his registered phone number. That will automatically get recorded. So that says that the patient has opened his tablet today. The patient has opened his tablet today. If the patient has not opened the tablet by 3 p.m., an alert will go to the patient. The alert will also go to the provider, whomever we fix, saying that your patient, Rajendran, who is on TB treatment, has not opened his tablet today. So this technology is called 99 dots. It's available in Kerala for all the adult patients. I already mentioned about direct benefit transfer of rupees 500 directly going into patient's account. This is the airborne infection control kit, which is being given to all TB patients in Kerala. It includes 5 cloth masks, a spittoon, and a phenyl solution. This is for proper disposal of the sputum, at the same time preventing the transmission within the households. What we have observed is most of the transmissions in Kerala, TB transmissions, occurs within the household. So household transmission is the most important route of transmission of TB in Kerala. So this is an important strategy. Every TB patient, we need to provide proper counseling and offer this kit so that he won't transmit this infection to anybody else. Handkerchief revolution is again another strategy where we have tried to teach school children about the cough etiquette. Don't spit in public places, cover your cough. So all schools in Kerala had undertaken, with the help of educational department, this handkerchief revolution. It says about when you are sneezing or coughing, cover your cough. This is not only important for TB, and I should not explain this in the context of COVID now. The most important, another important step is about the airborne infection control help desk at the hospitals. These are called cough corners or the airborne infection control help desk at the hospitals. Many of you might be aware of this. You might have seen this. You might have set up this. So this says this is whenever a patient is coming to the hospital. Now we know because of this COVID era, we know what to really do that. But all these things happened even before the COVID era. In 2019 itself, when the patient comes to the reception, anybody with cough will be offered a face mask, irrespective of whether he has TB or not. I repeat, anybody with respiratory symptoms, whether they have confirmed diagnosis or not, that doesn't matter. Most of the transmissions happens before the diagnosis of the disease. Once diagnosed, it's rarely a transmission happens, to be honest. So mask need to be offered to every respiratory symptomatics coming to the hospital. We need to educate them. We need to fast track them. So see, this is an OP ticket in a family health center in Kerala where they have put a green sticker. This green sticker means this patient need to be fast tracked. So that means the patient can jump the queue. The patient should not be asked to wait for a long time inside the hospital because we are suspecting an infectious disease in him. So it's for the benefit of all. This person may be allowed to jump pharmacy, jump laboratory queue, jump the doctor's queue, this kind of stuff. So this is known as fast tracking. This happens in many of the government facilities in Kerala. And as far as nurses are concerned, this is an important thing. There are 80 staff nurses who are diagnosed with multi-drug resistant tuberculosis who are on treatment in Kerala. I repeat, 80 staff nurses diagnosed with multi-drug resistant tuberculosis who are on treatment in Kerala. Don't be afraid. I am just adding to that. We have contacted all the staff nurses, all the nurses, and interviewed them, asked them, and finally, none of them were, 95% of them were not working in Kerala setting at all. Most of them were nursing students who were working in other states in India. And to my surprise, none of them gave a history of working in a TB setting at all. All of them were working in intensive care units, casualties, emergency rooms, and general medicine wards. I repeat, all the MDR TB cases that we got in Kerala, they never gave a history of working with a TB patient. They never gave a history of taking care of a TB patient. They were all working in casualties, intensive care units, and general medicine wards. So what is the message from that? I already mentioned that message. It's before the diagnosis that transmission happens. Once we got a diagnosis of TB or MDR TB, now we know what to do. We are safe. But most of the transmissions happens before the diagnosis at casualty, ICUs and all. So what could we do? set up airborne infection control facilities at the hospitals. Now we know what to do. Any respiratory symptomatics coming to hospital, offer them a mask. A patient with respiratory symptoms wearing a mask is the most important and critical intervention that we need to do to prevent transmission within the hospital. And second important intervention is open all the windows and doors. This air conditioner is basically, if you are not maintaining properly, if you are not maintaining the air current exchanges properly, especially split ACs, will put us at higher risk of developing airborne diseases, including tuberculosis. All these interventions are helpful not only for tuberculosis, but for many airborne infection control diseases. I am just summarizing. I know I have taken a long time. There is a system called Nikshay. Every information is digitally managed. Most of the staff nurses working in private sector knows about Nikshay. Especially they are the people who are running this STEPS model, which is now an acceptable international model that emerged from Kerala nurses. The Kerala nurses has shown the world that there is a model called STEPS, the system for TB elimination in private sector, which through which the patients are being followed up from the private hospital themselves and ensured all the public health actions, including the services I mentioned, and all informations are being shared in Nikshay platform. So there is a Nikshay is available. We will, if on further succeeding sessions, we will discuss about Nikshay. There are standards of TB care in India available. The standards of TB care in India is basically a document prepared by multidisciplinary team, including doctors from private sector, doctors from government sector, policymakers, TB patient, IMA, all the professional associations and all. They met together and they prepared standards of TB care in India. It laid down 26 standards which every TB patient in India should receive, irrespective of the facility where he is getting treatment from. He might be getting treatment from government sector, he might be getting treatment from private sector. Wherever he is getting treatment, we need to ensure that the patient receives these 26 standards. And this is something important that we really need to work on. And these 26 standards are simple. I already mentioned. Ask for screen for TB among the vulnerable individuals, offer them the right test, diagnose TB cases early, treat them with the correct drugs, treat them for 6 months, provide them public health actions, provide them with universal drug susceptibility testing, contact tracing to be done, INS prophylaxis to be given. All these are part of standards. And STEPS is one major initiative, like System for TB Elimination in Private Sector is one major initiative which has ensured, improved the standards of TB care for all the TB patients who are reaching the private sector in Kerala. And I once again congratulate all the nurses who are part of this STEPS team and made this dream a reality. Now this is an international model, and all credits to the staff nurses. You all know about TB is a notifiable disease. It's mandatory to notify TB. Not notifying TB is a criminal offense under Indian Penal Code section 269 and 270. It's a punishable offense. So we need to notify all tuberculosis. Notification simply means informing the public health authority that we are diagnosed a case of tuberculosis. There are also some incentives. For example, the hospital will get rupees 500 for notification, 500 for following up patient. The patient will receive rupees 500 per month. The tribal patient will get received 750 rupees. Also, the treatment supporter will receive another honorarium. So there are some incentives also available. And lastly, I would like to say that there are operations researches in tuberculosis. Lots of operations researches are ongoing. So nurses, nurses who are academicians, especially for the dissertation or for any other purposes, if you're interested, the state TB cell, like Dr. Sunil Kumar sir is sitting there, just write properly, apply to Dr. Sunil Kumar sir for permissions. The program will be supporting you for any operations research activities. Also, I am happy to announce that on last October 2nd, our Honorable Health Minister has declared that 561 panchayats had zero under 5 TB in 2019, 688 panchayats had 100% treatment success, and 700 panchayats had zero DRTB. But this is, we are nowhere near TB elimination, but these are some of the silver streaks that is helping us in going ahead with TB elimination. The next phases will be focusing on prevention of tuberculosis. And for prevention of tuberculosis, there are two important options available. One option is I already mentioned. We know that who is going to get TB. We know that TB is going to be a disease who has vulnerability. For example, a contact of TB with diabetes, he's at high risk of developing tuberculosis. So what to be done? Control his diabetes. A tobacco smoker with a contact, he's at high risk of developing TB. So what to be done? Cessation tobacco offers tobacco cessation services. A chronic respiratory disease patient with contact is at high risk of developing tuberculosis. What to be done? Link him to the Schwarz clinic of the government where or the private and manage his chronic respiratory disease properly. And the last slide of my presentation today, it talks about the right of every child to have a TB-free air. This is an initiative by Indian Academy of Pediatrics. The children cannot talk, so the doctors of children are talking for children. And they said that TB-free air is the right of every child, and protecting that right to achieve, to ensure that all our children born in Kerala are living in a world where they could breathe air free of Mycobacterium tuberculosis. That will be a big gift for our next generation that we need to provide. So we all need to work for achieving this status of providing TB-free air for every child in Kerala. There's one more important strategy which Dr. Ashraf sir will be discussing about the TB preventive therapy or the prophylaxis, which Dr. Ashraf sir will be discussing to you. So thank you so much for the patient listening, and thank you for giving me a wonderful afternoon today. I hope I have not taken a long time, and thank you for the patient listening.
Thank you, Dr. Rakesh, for that lucid presentation. You have done an overall view of the TB presentations in our state and in the country, and highlighted the role of nurses in TB elimination. There may be some questions coming that we will discuss at the end. Now it's over to Dr. Ashraf, TP Ashraf. Dr. Ashraf is an additional professor of pediatrics at Calicut Medical College, Calicut, and he is a convener of TB elimination program in children for the state of Kerala. Over to Dr. Ashraf.
Thank you, Dr. Narayanan. Whether my slides are visible?
Yes, yes.
1 minute. Okay, thank you, Dr. Narayanan. Dr. Rakesh gave an excellent talk on the tuberculosis, about the National Tuberculosis Elimination Program, and about the Akshaya Kerala, that is the National Tuberculosis Elimination Program, which was implemented in the name of Akshaya Kerala in Kerala, about the objectives of the National Tuberculosis Elimination Program, about the strategies, about the social support under the program. Next 30 minutes, I will try to tell something about the tuberculosis in children, which is quite different from adult, and also about the management of latent TB infection in children, which is the key strategy, key step towards the elimination of TB in Kerala or in India. Dr. Rakesh, Dr. Narayanan, and Dr. Sunil Kumar already mentioned about the tuberculosis elimination, and our state president included this activity, the prevention of tuberculosis, TB-free air for every child in Kerala, in his presidential action plan, which is well supported by the state TB cell. Then, regarding the TB in children, from where a child gets to TB infection, usually it is from an adult. There will be a source case. Usually the source case may be, in case of children, a family member in most of the occasion. And only 70% of the contacts, only 30% of the contacts will get infection, and 30%, 70% will not get infection. Suppose there is a family contact, the chance to get infection for a child, for a contact is 30%. 70% of the occasion, there will not be infection and there will not be any TB disease. And out of this 30%, 90 to 95% of infection become persistent infection, or it is otherwise known as latent TB or latent TB infection. There will not be any signs or symptoms of TB in this group. But 5 to 10% will develop primary disease, which is well known as a primary complex. There is a foci in the lung, there will be draining lymphatics, that is called primary complex. And this primary complex may progress. It can erode a bronchi, it erode the lung tissue, it can rupture into the pleura. This is called progressive primary complex. In this primary disease, there will be symptoms. There will not be any symptom in latent infection. And what decides why some of children get disease, some of the children get only infection, some of the children or contacts will not get infection? It depends on two factors. One is virulence of the causative organism, mycobacteria, and the host immunity. We all know children are prone to get transient or temporary immunodeficiencies due to various causes like underweight, severe acute malnutrition, measles, whooping cough. So the chance to develop a TB disease is only 5 to 10% in lifetime, but it is more in infancy. That means in the first year of life, that is more than 50%, and it is more when compared to the whole life in children in the age group of 1 to 5 years also, that is 25%. So the pediatric TB is important. Then, what are the symptoms of TB in a child? Dr. Ragesh already mentioned about the symptoms, that is persistent fever more than 2 weeks duration, unremitting cough more than 2 weeks duration, weight loss or no weight gain in past 3 months despite adequate nutrition, or failure of nutritional rehabilitation in babies with severe acute malnutrition. In all these clinical settings, we should suspect a tuberculosis, whether there is a contact or whether there is no contact, with or without a contact of a patient with a pulmonary tuberculosis. So the hemoptysis is not a common symptom in children, and the night sweats also not a common symptom in children. Other three, that is fever, cough, and weight loss. And the first investigation we will do in pediatrics is little bit different from an adult, is chest X-ray. And if chest X-ray, if there is a highly suggestive features, for the tuberculosis, the highly suggestive features means if the chest X-ray shows a lymphadenopathy, hilar adenopathy, or fibrocavitatory change, or miliary mottling. These are the highly suggestive lesion for tuberculosis in pediatrics. We will collect a sputum sample. We all know it is very difficult to get a sputum sample in a young adult. So there are some techniques. The role of practicing nurses is there in collecting this adequate sputum specimen, either through the gastric aspirate or induced sputum, which will be sent for the rapid diagnostic test. Dr. Ragesh already mentioned that is the TrueNat or a gene expert. The machine name is gene expert or TrueNat, and we are doing NAT means nucleic acid amplification test. And if the NAT is positive, that's a microbiologically confirmed case. Along with that, we will check whether the strain is sensitive for the rifampicin. So if it is a sensitive to rifampicin, we will follow the treatment guideline for the sensitive TB. And if it is a drug-resistant TB, which is quite rare in the pediatric age group, we will follow the drug-resistant TB algorithm. Suppose if the child is NAT is negative, still we may send another sample for the NAT, and we will go for other alternative diagnostics like BAL, bronchoalveolar lavage, or a lymph node, if there is a lymphadenopathy, aspiration for the other techniques we will. And we will send the sample again for the NAT, and if the NAT is positive, it is a microbiologically confirmed TB. Suppose the sex X-ray shows non-specific changes like consolidation, we will give a course of antibiotic and repeat the X-ray, and the shadows are persisting. It is not disappearing after the course of antibiotic. We will go for the expectorated sputum, and we will send the sample for the CB-NAT. This is the diagnostic algorithm followed under the program for diagnosing tuberculosis in children. Suppose the chest X-ray is normal, we will evaluate for the extrapulmonary TB. And if the facilities are not available in our center, we will send that child to the higher centers. And it is already mentioned, the sputum examination, the microbiological confirmation by CB-NAT is a frontline investigation in the tuberculosis. That is also essential to detect whether the microbacteria is sensitive to the rifampicin or anti-tubercular drugs, or it is resistant. So the drug-resistant tuberculosis is another public health problem. So for the microbiological confirmation, the sputum sample is very important. There are some hurdles in children. Most children do not expectorate. Even if they have sputum, do not cough violently enough to bring it up, tend to swallow rather than to spit it out. Unlike adult, the specimen needs retrieval in children. Here, there are two techniques are there. One is gastric aspirate or gastric lavage, and another is induced sputum. We will have beautiful videos of both this gastric aspirate as well as the induced sputum. I will show that video at the end of the session, rather than going and boring you by repeatedly reading the steps about the gastric aspiration. If there is any doubt regarding this induced sputum or gastric lavage, we will discuss at the end of the session after seeing that videos. So I am not going through these slides. We will see the video at the end of the session. Then, if a case is diagnosed, we will treat it. And we all know the multiple drugs are used in treatment of the tuberculosis. Why we are using multiple drugs? The reason is, in a patient with tuberculosis, there are various types of mycobacteria there. One group is called type A, actively dividing organism. Here, most useful drug is INH, then streptomycin, then rifampicin, and ethambutol. So the INH is the most effective drug against the actively dividing mycobacteria in the lung. There is another group called intracellular slowly multiplying organism. Only pyrazinamide is effective against this group. And another group is extracellular slowly multiplying organism and spreaders. In this group, rifampicin and INH are useful drugs. This is the rationale behind using multiple drugs in treating tuberculosis. Then, previously, there are several regimes for the treating pediatric TB. Now, 2019 onwards, there is only one regime. Whether it is a new microbiologically confirmed pulmonary TB or new clinically diagnosed pulmonary TB, new microbiologically confirmed extrapulmonary TB like tuberculous lymphadenopathy, new clinically diagnosed extrapulmonary TB, drug-sensitive previously treated TB, all single regime is there. That is for 4 drugs for 2 months plus 3 drugs for 4 months. 2 HRZE means 2 months INH rifampicin pyrazinamide ethambutol combination followed by a 4 months INH rifampicin ethambutol combination. This second phase is 10 months for the neurotuberculosis. If it is a tuberculous spine or if it is a tuberculous meningitis, we will give INH rifampicin and ethambutol for 10 months. The total duration is 12 months. All other groups we will give, it is for total duration is 6 months. 2 months INH rifampicin, pyrazinamide and ethambutol, both the groups, whether it is tuberculosis, meningitis, neuro-TB or other group of TB. But for the neuro-TB, this continuation phase is 10 months instead of 4 months. Total duration is 12 months there. In all other cases, the total duration is 6 months. Then, this is one of the most important concern of nursing staff who directly take the care of patients, whether it is TB patient or any other patient, that there may be some adverse effects due to drugs. And most of the occasions, this adverse effect will appear in the early months of treatment, especially the hepatotoxicity. The INH is a hepatotoxic drug. Rifampicin is a hepatotoxic drug. Pyrazinamide also is a hepatotoxic drug. So we are using 3 hepatotoxic drugs. There is a chance to develop hepatotoxicity. We should pick it up early. The earliest symptom of hepatitis is not jaundice, it is nausea and vomiting. Suppose any child on ATT or an anticonvulsant develops nausea or vomiting, please exclude hepatotoxicity. The jaundice, the overt clinical jaundice may be little bit late. So if suppose a child develops nausea or vomiting, think of hepatotoxicity if the child is on ATT. INH also rarely leads to peripheral neuropathy. And ethambutol, ocular toxicity, optic neuritis, which is not so common in our children, and the streptomycin, which is not used commonly. If some of the drugs are resistant to mycobacteria, we may opt for streptomycin. Otherwise, routinely we are not using streptomycin. It is well known for the ototoxicity. So INH, rifampicin, pyrazinamide, all these 3 drugs are hepatotoxic. So look for the hepatotoxicity in the history of nausea and vomiting may be the initial feature of sign of symptom of hepatotoxicity. Then that is about the first part. We discussed briefly about the tuberculosis in children. What is primary complex? What is progressive primary complex? And what are the symptoms of progressive primary complex? What are the symptoms of primary complex? And how we will treat the primary complex or progressive primary complex or any other TB in children. The second half of the talk is about this persistent latent infection. We already said from the source case, only 30% will develop infection, out of which the lifetime risk for developing disease is only 5 to 10%. All other 90 to 95% of children, the infection is a latent infection. But for the latent infection, there's a chance of reactivation at any time of life. But the chance is more during the first 5 years after getting infection. So suppose a child is having a family, 1-year-old child having a contact with a microbiologically confirmed pulmonary TB in the family, he may get an infection and chance to develop disease during the first 5-year time, that is up to 6 years in that case, is more. So whether we have to treat this latent infection or not, that is the point of discussion. And for the TB elimination, that is the strategy of the WHO to treat this latent infection, especially in children under the age group of 5 years, and also in children and adolescents under the age group of 18. So, prevention of active TB disease by treatment of LTBA is a critical component of WHO and TB strategy. So, what is latent TB? I already said for the primary complex, for the progressive primary complex, there will be symptoms suggestive of TB like fever, cough, or weight loss. But in latent TB, the antigen test may be positive, the Mando test may be positive, the IGRA test may be positive, but the child may not have any symptoms like fever or cough or weight loss. So there will not be any symptom, but the child is harboring the dormant tuberculosis bacilli and the antigen Mando test or IGRA test will be positive. That is a immunological response to stimulation of the mycobacterium tuberculosis. That is latent TB. And under the Akshaya Kerala program, we are now going to treat all latent TB infection in children and adolescents. And these are the eligible group. Any child under the 5 years of age, who are household contacts of microbiologically confirmed pulmonary TB, they will be offered to treatment of LTBA. Then a child, even though rare, a child born to mother who was diagnosed to have a TB in pregnancy, any type of TB during the pregnancy, that newborn baby also will be treated for the latent TB infection after ruling out the congenital tuberculosis. Then children and adolescents in the age group of 5 to 15 years who are household contact of microbiologically confirmed pulmonary TB should be systematically tested for LTBA. If found to have LTBA, they shall be offered treatment for the same after ruling out active TB. Any child, any family contact of in the age group of 5 to 15 years, they will also offer the TB preventive therapy or treatment for the latent TB infection after ruling out the TB disease, after ruling out the active TB. Then children and adolescents in the age group of 12 months to 15 years living with HIV should be given TB preventive therapy, even though there is no contact in the family. For any child, the number of children living with HIV/AIDS are drastically decreasing in Kerala because of the several activities implemented by the NACO and state AIDS control cell. So, but if any child living with HIV/AIDS in the age group of 12 months to 15 years should be offered TB preventive therapy after ruling out the active disease, and the children living with HIV/AIDS less than 12 months of age should also given TB preventive therapy if there is a contact in the family with the pulmonary TB. അപ്പോൾ 1 വയസ്സിന്റെ താഴെയുള്ള കുട്ടികൾക്ക് വീട്ടിൽ ഒരു പൾമണറി TB കോണ്ടാക്ട് ഉണ്ടെങ്കിൽ മാത്രമേ നമ്മൾ HIV ഉണ്ടെങ്കിൽ കൊടുക്കുന്നുള്ളൂ. മറ്റേ ഗ്രൂപ്പിന് 12 months to 15 years, even without a contact, we have to offer LTBA treatment, that is TB preventive treatment. LTBA means latent TB infection treatment. Then the other group is, you all know during your posting in pediatric ward, if suppose in a case of nephrotic syndrome, before starting steroids, we will take a chest X-ray as well as Mando test to exclude a primary complex. And if the X-ray is normal and the Mando is positive, we will give INH prophylaxis. Any immunosuppressive drugs like steroid, any condition, we are giving an immunosuppressive drug like nephrotic syndrome, acute leukemia, we will rule out LTBA by doing the test. Then if the test is positive, the Mando test at that time, in this program we are using IGRA test. IGRA is positive, we will give TB prophylactic treatment. These are the groups of children to whom we will consider LTBA treatment. And I repeatedly said the term household contact. What is a household contact? A person who shared the same enclosed living space as the index patient for one or more nights, or for frequent or extended daytime period during the 3 months before the start of current treatment. അപ്പോൾ വീട്ടില് ഒരു ഗ്രാൻഡ് ഫാദറിന് TB ഉണ്ടായിട്ടുണ്ടെങ്കിൽ അത് ഇന്നാണ് ഡയഗ്നോസ് ചെയ്യുന്നതെങ്കിൽ അദ്ദേഹത്തിന്റെ കൂടെ ഒരു രാത്രിയോ പകല് 2-3 മണിക്കൂറോ ചെലവഴിച്ച ഏതൊരാളെയും നമുക്ക് കോണ്ടാക്ട് ആയിട്ട് എടുക്കാം. അതിൽ 5 വയസ്സിന്റെ താഴെയുള്ള കുട്ടികളാണെങ്കിൽ നമ്മൾ അവർക്ക് സിംറ്റം, ഇഫ് ദർ ഇസ് നോ സിംറ്റംസ് ഓഫ് TB ലൈക്ക് fever, weight loss or cough more than 2 weeks duration, we will directly start LTBI treatment or preventive therapy against tuberculosis. Suppose that child is also having the symptom, we will exclude active TB first. And in children in the age group of 5 to 15 years, in that family, we will ask for the symptoms of TB. If there is symptom, we will exclude the tuberculosis, active TB as per the algorithm, as I already shown in the beginning of this talk. And if there is no symptom, we will do an IGRA test. And if IGRA is positive, we will take an X-ray. And again, we rule out an active tuberculosis. The X-ray is normal, IGRA is positive. That child also will be given TB preventive therapy. Then, testing of LTBI. To diagnose LTBI, in this program, we are going to use IGRA, which is not essential in a child under the age of 5 years. For other group, 5 to 15 years, we are giving prophylaxis only after IGRA positivity. Then this is about the IGRA test and age-old tuberculin skin test, that is Mando test. And this is algorithm I already discussed. If the child is in the age group of 5 to 15 years, there is a family contact of pulmonary TB in the family. If the symptoms are present, we will exclude the active TB first. If no symptom, we will do an IGRA. And if the IGRA is positive, we will take a chest X-ray. And if chest X-ray, any abnormality, any mediastinal lymphadenopathy, such things, we will again exclude an active TB. And chest X-ray is no abnormality. We will look for any other signs or symptoms of TB in the form of lymphadenopathy or organomegaly. Nothing is there. We will give that child the preventive therapy for the latent TB. Then these are the various regimes. Previously, we are using INH for 6 months, but this program we are going to give INH and rifampicin for 3 months. That is the treatment for latent TB infection in any child or adolescents under the age of 15 years. These are the rationale why we choose 3HR rather than 6H. And the dose is, if the child is age 10 years and above, 5 milligram per kg. If the child is less than 10 years, 10 milligram per kg. Range is 7 to 15 milligram for the INH. And similar dose for the rifampicin is in the age group of 10 years and older, 10 milligram per kg per day. And in less than 10 years, 15 milligram per day. The range is 10 to 20 milligram for the rifampicin. That is the dose of INH and rifampicin. You all know the fixed drug combinations are available under the program, and this is the weight bands and the corresponding number of fixed drug combination of INH and rifampicin. And in these cases, we will not consider LTBI treatment directly. Suppose a family, the grandfather is having a pulmonary tuberculosis, which is microbiologically confirmed and which is drug resistant also. We will not straight away give them INH prophylaxis because it may develop drug resistance. And also we will rule out any liver disease is there, any liver problem is there before starting the prophylaxis treatment. And active hepatitis is also a contraindication for the preventive therapy and symptoms of peripheral neuropathy also. So the Akshaya Kerala is a teamwork. The government has a main role in it. Doctors is having the role, but especially for the microbiologically confirmation and counseling, the practicing nurses is having a big role. Also to counsel about the social support system prevailing under the scheme. So that is the main motive behind organizing this session. Thank you all. Thank you for the patient hearing. And now I will share how we will do induced sputum as well as how will you do gastric aspirate. 1 minute. This is the video about the gastric aspirate.
The other way of accessing sputum or respiratory secretions in small children who tend to swallow it is to collect it through the stomach. And that can be done if the stomach contents are not mixed with any food articles, which means we need to do this procedure after either an overnight or a few hours of fasting. So often we call these children after an overnight fasting, put in a tube into the stomach and collect all the secretions which the child may have swallowed during the night. We call this procedure as either gastric aspirate, or sometimes, since the aspirate alone will not be enough to get the material from the stomach, we may have to put in some saline to lavage it. So it is also called as gastric lavage. In this clip, we learn about gastric aspirate or gastric lavage.
To begin with, explain the procedure and take consent from the parent or guardian. Patient should be fasting for 4 to 6 hours prior to collection procedure. In an admitted child, it may be done early in the morning while the child is still asleep and in bed. Instruments required for the procedure are normal saline, pair of sterile gloves, Ryle's tube or infant feeding tube, adhesive tape, lubricant jelly, 5 ml syringe, sterile specimen container, face mask, sterile gauze, and measuring tape. Place the patient in a supine position and restrain using the long folded sheets. One end of a folded sheet is pulled over the back of the child, looping through both the arms as shown. The other end is then rolled over the arms and wrapped around the child, moving from back to the front and then to the back. The lower end of the sheet should be reaching the wrist of the patient for effective restraint. One could make this measurement directly using the tube or else using a measuring tape. The Ryle's tube needs to be placed in the body of the stomach through the nose. The required length of the tube to be inserted can be ascertained by measuring the distance from tip of the nose to the tragus and then from tragus to the midpoint between xiphisternum and umbilicus. Apply lubricant jelly to the tube. Gently insert the tube through the nose in a direction perpendicular to the face up to the measured length. This can often be assisted by asking the patient to swallow. Fix it to the nose with an adhesive tape. It is important to confirm that the tube is correctly positioned in the stomach. This can be ascertained by pushing some air with a syringe into the tube and simultaneously auscultating for gush of air over the epigastrium with a stethoscope. In case the patient starts choking or coughing while inserting the tube, then the tube should be withdrawn and reinserted after the patient has settled. Once the right tube has been inserted into the stomach, its position can be checked by hearing a gush of air over the epigastrium. We can also aspirate the stomach contents to confirm the position. Gently aspirate from the tube, keeping the patient in the supine position. If there is no aspirate or the quantity is inadequate, try re-aspiration after shifting the patient in the left and right lateral positions. If one still does not get adequate specimen in both supine as well as lateral positions, further aspiration can be retried by shifting the tube a little in or out in an effort to hit the stomach contents. The repeat aspiration should be done while rotating the patient through supine and lateral positions. In case direct aspiration fails to provide adequate specimen, one should instill about 10 ml normal saline through the tube slowly. Align it to gravitate on its own. After instilling, re-aspirate, rotating the patient through supine as well as left and right lateral positions. Repeat these steps till gastric aspirate is obtained. Collect the aspirate in a sterile container. A specimen is considered adequate if it contains about 10 to 15 ml of stomach contents. After collection of gastric aspirate, gently remove the tube by closing its cap or pinching the tube. "50 ml conical tube is another type of container which can be used for sample transport instead of the disposable container shown in the video. As conical tube can be put directly into centrifuge machine, it is preferred when the sample is to be subjected to mycobacterial culture and drug sensitivity. This is also the preferred container for samples being sent to National TB Program labs, as it does away the need to transfer the specimen from one container to another."
That is about the gastric aspirate, which is a very easy procedure to all the practicing nurses. But the one thing is important: don't instill the normal saline first. Try to aspirate directly first. If it fails, then only instill the normal saline. Next video is about the induced sputum. I will share it now. 1 minute. So now I think it is visible now. Okay.
Pulmonary tuberculosis requires access to respiratory specimen. In adults, it's simple because they can bring up sputum and give it voluntarily. However, children often tend to swallow it and are not able to produce sputum at volition or command. This makes collection of respiratory specimen little difficult in children. How does one access specimen in children with these difficulties? There are two ways it can be done. One way is by inducing sputum and collecting it through nasopharynx, or the other way is to collect it through the gastric aspirate. The first method, which is called induction of sputum, is largely used for children who either are not producing any sputum or are very young and are swallowing it up. In this situation, we prime them with a dose of salbutamol and follow it up with a 3% hypertonic saline nebulization. Priming is necessitated because 3% hypertonic saline can provoke bronchoconstriction in some children. To avoid that, we give them salbutamol either by nebulization or by MDI with spacer. After initial priming with salbutamol, 3% hypertonic saline is given by nebulization. This stimulates production of secretions in the respiratory passages. An older child may be able to cough out these loosened secretions on its own during the process of 3% hypertonic saline nebulization, while a younger child may need further assistance. For loosening up these secretions, in a younger child, one may have to do chest percussion. Even after chest percussion, a younger child, when he coughs up the sputum, will tend to swallow it. So how does one trap these secretions before they are swallowed by the child? One way to do it is to use a suction trap attached to either a suction machine or a wall suction port. The suction trap, when it is introduced into the nasopharynx of the child, stimulates cough. So as the loosened secretions come into the nasopharynx, before the child has a chance to swallow it, it is trapped by the suction and collected in the suction trap. This way, one can access the loosened secretion after inducing them with hypertonic saline.
Explain the procedure and take consent from the parent or guardian. Patient should be fasting for 2 to 3 hours prior to collection procedure. Instruments required for the procedure are disposable gloves, hypertonic 3% saline, syringe 10 ml size, needle, adhesive tape, sterile specimen container, sterile gauze cotton, nebulization chamber with oxygen tubing and mask, salbutamol, and mucus extractor or suction trap. Procedure should be performed in a well-ventilated room, having an exhaust fan while wearing a N95 face mask. Baseline values of respiratory rate, pulse rate, chest retractions, V's, and oxygen saturation should be taken prior to the procedure. Priming with salbutamol can either be done through metered dose inhaler, that is MDI, or nebulization using either respiratory solution or Respule. MDI has an advantage that it takes less time and is as effective as nebulization. However, nebulization facility is essential to give 3% hypertonic saline. Instruments required for this procedure are inhaler and spacer. A mask is attached to spacer in case of a young child. Salbutamol is administered by sequentially giving 2 puffs, that is 100 micrograms through MDI with a spacer. This prevents bronchospasm from 3% hypertonic saline nebulization in children predisposed to it. Alternatively, administer salbutamol by nebulization using respiratory solution or Respule. The neb respirator solution contains 5 mg of salbutamol per ml. The dosage for administration is 0.15 mg per kg. Taking age into consideration, the administered dosage varies as shown on the screen. For neb Respule, use equivalent doses as respirator solution. Fill up the required amount of salbutamol from respiratory solution or Respule. Load the drug formulation to the nebulization chamber. Add saline if required to ensure that volume of formulation in the chamber is above its minimal fill volume as shown. The next step is to nebulize with 5 ml of 3% sterile hypertonic saline. Use a sterile, commercially available preparation. Nebulization can be done through a jet nebulizer attached to pressured oxygen or air supply at the lowest flow rate needed to produce adequate mist, which usually is 5 to 7 liters per minute. While the child is being nebulized, give a container to the child to collect any expectorated sputum. As evident, this child has started expectorating while being nebulized with 3% saline. If the sample is adequate, then the procedure may be wrapped here and expectoration may be sent to lab for further processing. The characteristics of good sputum specimen are desirable quantity of 3 to 5 ml, presence of mucoid or mucopurulent material, color varies from opaque white to green, should be brought up from inside the chest by a deep cough and should not be oropharyngeal secretion or saliva. Few children will only produce or bring up saliva or no expectoration on their own after 3% hypertonic saline nebulization. In such situations, one can loosen up secretions and assist child in secreting sputum by chest percussion. The purpose of chest percussion is to bring the secretions from the peripheral to central airways, from where the child can cough out the secretions. Palm of the hands while doing percussion should be made into a cup shape formed by the fingers and the thumb instead of a flat open hand. This avoids hurting the child. For younger children, it is ideal to percuss with fingers. Movement while percussion should be at the wrist and not elbow or shoulder. For percussion, we must cover all areas of chest in sitting, supine and prone positions. If there is sputum production and child can expectorate, collect the sputum in sterile container. If still child is unable to expectorate, or if it is a young child who needs assistance to collect secretions, then sputum can be collected by suction through nasopharynx or oropharynx. Use sterile mucus extractor or suction trap with the other end of the extractor connected to gentle suction of around 100 centimeters of water. The catheter is inserted through the nose. The length of the tube to be inserted is measured from side of the nose to the angle of the mandible. Apply lubricant jelly or wet the tube. A few children get scared, however, this procedure is not painful as evident in another patient. The catheter is gently inserted into the nose in a direction perpendicular to the face. Release suction. As the catheter touches the posterior pharyngeal wall, it can provoke cough. The loosened secretions are brought up with the cough, and suction will facilitate its collection in mucus extractor or suction trap. In this child, as you can see, respiratory secretions have been collected. This should be immediately transported to Gene Expert lab. Monitor for 30 minutes after the procedure for respiratory complaints like respiratory rate, pulse rate, chest retractions, wheeze, etc. Fresh, sterile disposable tubing and chamber for nebulization should be used for each patient. So, you learned that for induction of sputum, first step is to prime with salbutamol either by using MDI or nebulization using respiratory solution or Respule, followed by nebulization with 3% hypertonic saline. If no expectoration, chest wall percussion is done. If still no expectoration, collect sputum by suction through nasopharynx or oropharynx. 50 ml conical tube is another type of container which can be used for sample transport instead of the disposable container shown in the video. As conical tube can be put directly into centrifuge machine, it is preferred when the sample is to be subjected to mycobacterial culture and drug sensitivity. This is also the preferred container for samples being sent to National TB Program labs, as it does away the need to transfer the specimen from one container to another.
But that is about the induced sputum. Well, there are two techniques to collect sputum in children. As the children are not actively expectorating because of the young age, or they are swallowing the sputum. And these are the two techniques. One is gastric aspirate is well versed in by nurses, but the induced sputum is an easier technique. There is no at any time of the day we can collect the sputum by the induced sputum, but in the gastric aspirate we prefer early morning sample. That is about the TB in children. If you are having any questions, you can either directly ask the question or you can type it in the chat box about any aspect of the pediatric tuberculosis, and as well as the about the program implementation and program about the national TB elimination program. I think Dr. Ragesh is also there. Yes. Biju?
Hi,
Biju,
sir. Any questions you can ask? You can ask of also put the questions in the chat box.
Slides are self-explanatory. Will you please send the slides to mail? Slide എന്തായാലും mail അയക്കാം. അതല്ല കുറച്ചുകൂടി slide ഉള്ളത് അയക്കാം. Okay. I will mail it to Biju or Sona. You can
Okay,
share
sir.
in your group.
Okay, sir. We will share in the groups.
രാകേഷ് നമുക്ക് വൈൻഡപ്പ് ചെയ്യാൻ തോന്നുന്നു. രാകേഷ്.
Arshad is the consultant STDs.
അർഷദ് ഉണ്ടോ? ഡോക്ടർ അർഷദ് ഉണ്ടോ?
ജോയിൻ ചെയ്തിട്ട് എന്തെങ്കിലും ഒരു മിനിറ്റ് പറയാനുണ്ടെങ്കിൽ കേൾക്കാം.
Yes.
ഒന്നുമില്ല രാകേഷ് ഒന്നുമില്ല. നമ്മുടെ അമർ ഫെറ്റിൽ സാർ ഇവിടെ വന്നിരിക്കുന്നു, പ്രത്യേകിച്ച് ഒരു കാര്യം സംസാരിക്കാൻ വേണ്ടിയിട്ട്. അതുകൊണ്ടാണ്. വേറെ ഒന്നുമില്ല, എസെൻഷ്യൽ ആയിട്ടൊന്നുമില്ല.
Thank you TNA for organizing this program along with the IAP as well as the state TB set. Thank you Dr. Sona as well as Dr. Biju for the organizing.
Thank you, sir. Thank you.
Rakesh, concluding remarks.
സർ ഞാൻ നേരത്തെ പറഞ്ഞല്ലോ സ്റ്റാഫ് ഇവിടെ ഉണ്ട് തീർച്ചയായിട്ടും
You are not audible, I think, Rakesh. Little more.
കേൾക്കാം സർ.
Yeah. Now it is okay.
I think, hello, am I audible now?
Now you are audible. Just ഞാൻ ഒന്ന് മ്യൂട്ട് ചെയ്യാം. ഞാൻ അൺമ്യൂട്ട് ചെയ്ത് സംസാരിച്ചോ, കാരണം ബാക്ക്ഗ്രൗണ്ട് നോയ്സ് ഒഴിവാക്കാൻ. You unmuted.
Right. Thank you, DNA, for this wonderful initiative. We know staff nurses are always part and parcel of all healthcare delivery. So for TB elimination mission also, it's same. Like staff nurses play, or the nurses play a very important role. So let's work together as a team to ensure that all our children will breathe air free of mycobacterium tuberculosis in near future. So we are all with you in your fight against to improve the health of people in India. Thank you so much.
Sir, feedback form is posted in the chat box. Participants can fill it so that they will get the certificate.
Dr. Sana, നമുക്ക് കൺക്ലൂഡ് ചെയ്യാൻ തോന്നുന്നു അല്ലേ? Over to Sana, any comments? Unmute ആവണല്ലേ?
മാഡം മ്യൂട്ട് ചെയ്തിരിക്കുക. മാഡം മ്യൂട്ട് ചെയ്തിരിക്കുന്നു.
Hello.
ഇപ്പൊ കേൾക്കുന്നുണ്ട്. Okay.
Okay.
Audible.
That was a very informative session, and we can do much better with the present class. And actually, we got more information through these classes. Okay, so you have already said we can share the slides, and we can share the slides to our nurses group so that more and more nurses get aware about it. So thank you, sir, for joining with us, and hope we will join hand in hand in future too. I think Viju can formally give the vote of thanks now.
Okay, thank you, madam. Yeah. Good afternoon to you all. First of all, I like to thank Dr. M. Narayanan sir, IAP State President, and his team for collaborating with the TNI for this wonderful webinar. And I also like to thank Dr. Sunil Kumar, State TB Officer, who was behind this venture.